In our next cardiac video, we're going to talk about heart failure. So what is heart failure? Heart failure is when the heart is not able to supply the body with oxygen. So there's a decrease in the heart's function, whether it's a problem with the pump itself or the filling of the ventricles. Those are the more common kinds. It's not perfusing the body. So you have decreased perfusion, fluid volume imbalance, impaired gas exchange, and then decreased functional ability for our patients. Some statistics when it comes to heart failure. It is the most common reason for hospitalization in adults over the age of 65. It is a huge burden on the healthcare system. A quarter of the patients hospitalized for heart failure are readmitted within 30 days. So we have hypertension and coronary artery disease are both primary risk factors for developing heart failure. You also have certain comorbidities and modifiable risk factors that increase the incidence. So tobacco use, diabetes, increased age, the patient can have congenital abnormalities or dysrhythmias, alcohols, drugs, chemotherapy can also affect the heart itself. So there's a lot of different risk factors that can increase the risk for heart failure in our patients. So when it comes to heart failure itself, like I said, it's usually an issue with the pump itself or an issue with the ventricles filling. So there's HFrEF, which is heart failure with reduced ejection fraction. This is when we have impaired squeezing, so something's wrong with the pump. Whether it's from a heart attack that has created damage to the muscle, or maybe our afterload is so high that the pump can't really pump against it. We could have a valvular disorder. So again, we're just not pumping very well because we're losing some of that blood through the valves that have issues. And then we have heart failure with preserved ejection fraction, or HFpEF. This is when the pump it's still pumping okay, but we can't fill the ventricles very well. And it's usually because the ventricles are so stiff. Hypertension is the primary cause of this. And so ejection fraction, I've mentioned, is basically how much your heart is able to pump out. So a normal ejection fraction is 55 to 65%. Heart failure is when we're less than 40%. I have seen an ejection fraction as low as 5 to 10%. Again, these patients are very winded, very exhausted, can't do much because they're not pumping much of that blood. And so there's left-sided versus right-sided heart failure. Left-sided heart failure is when the left side of the heart stops working very well. And so the fluid will start backing up from where the left side gets the blood, which is the lungs. So the fluid builds up in the lungs. We get dyspnea, crackles in the bases of the lungs. This can be seen on chest x-ray a lot of the time. And I always try and help you guys remember these things. So left-sided heart failure, left lungs, right? So left-sided heart failure builds up in the lungs. Right-sided heart failure is when the right side of the heart stops working as well. And so the fluid builds up in the tissues and the organs. So you can get like ascites build up in that, in the liver. You can get peripheral edema. You could get jugular vein distension. Left-sided heart failure is the most common cause of right-sided heart failure. So a lot of the times when patients will have one side, it eventually goes to both sides. And so the patient can actually have remodeling of the heart as they go through heart failure. This results from some of our compensatory mechanisms that work at first. And so they're great in the beginning, but when it leads to this remodeling, it can lead to longer term issues. And so the Frank-Starling law is this idea behind the strength of a heart contraction is directly related to its diastolic expansion. So how much can that heart stretch? The farther it can stretch, the more it will actually contract. But the problem is that we could stretch the heart too much and we can start to get these enlarged ventricles and enlarged atria, which then leads to a weaker contraction over time. That excessive preload exhausts the mechanism that we were just talking about. We stretch out those muscle fibers, and so then the preload no longer works. Another change would be like the thickening of this heart muscle because it's trying to pump so hard. Then our ventricles start to get so small that we can't fill it with fluid. So again, our body has these compensatory mechanisms that increase stretch or that increased pumping, but eventually as the heart remodels, it can cause further issues. The other things we watch out for heart failure is we have these natriuretic peptides. And so this is released in response to the ventricle walls stretching. And so the big thing to know is the BNP, I know it says brain, it's the B-type natriuretic peptide that is released from the ventricles. And a high BNP is what we're looking for when we're diagnosing heart failure, and we're also seeing how bad it is. So a high BNP correlates with fluid retention and an increased mortality in our heart failure patients. And so these natriuretic peptides actually have a beneficial effect for our heart failure patients. So they impact the renal system by increasing our glomerular filtration rate and have the patient diurese off some of the water and sodium that they may be retaining. It also helps the cardiac system or the vascular system vasodilate and decrease the blood pressure. And then hormonally, it helps inhibit aldosterone, renin, and our ADH mechanisms, again, helping to kind of keep our cardiac output down and help get off some of these fluids and sodium that the patient may be retaining. And again, this is the lab test that we are checking for in our heart failure patients. So a high BNP correlates with a higher fluid retention, and it is a predictor of mortality in our heart failure patients. So we have all these mechanisms in place, and the patient can go for a long time. They can compensate for a long time, but then they can get decompensated, whether acutely or not. But an acute decompensation is basically an acute worsening of the heart failure. So those mechanisms in place are no longer adequate, are no longer adequate to maintain cardiac output, and so we're having inadequate tissue perfusion. So they have pulmonary edema, so they have that buildup of fluid in their lungs. They're dyspneic, they're orthopneic, so they have to stay sitting up, they can't lay down. They might be breathing faster. They have this paroxysmal nocturnal dyspnea, which is when they could be sleeping and they wake up all of a sudden and they just can't catch their breath. And so for paroxysmal nocturnal dyspnea, it's all of a sudden, it wakes the patient up while they've been sleeping, but it can be relieved if they sit up and kind of dangle their feet over the edge of the bed. That's the same for orthopnea too. We want to get these patients in high Fowlers, and dangling the feet can help instead of having the feet elevated because it helps shift some of that fluid down into the feet, down into the periphery. And so this acute decompensation, this is a lot of the time what patients are coming into the hospital with and what they need to be hospitalized for. Chronic heart failure, again, symptoms are going to be somewhat similar. They're just not as life-threatening. And so which out of these, like when you're looking at these symptoms, is going to be the most concerning? Because it's kind of a trick. It's not necessarily ABCs, because these patients are going to chronically be dyspneic because they've got fluid in their lungs chronically. So they're always going to feel a bit short of breath. The big one that I'm watching out for, that I'm concerned about, is this altered mental status, because that means that they're not getting oxygen to their brain. So chronic heart failure, like I said, it's similar to that acute decompensated, but it tends to be less severe, and they can usually manage this at home. The patients do need to be weighing themselves every day to kind of watch for fluid retention and fluid shifts. When we're treating heart failure, we are definitely using diuretics. That's our first-line treatment for acute exacerbations as well, because we're trying to get off this excess fluid. And so we're trying to get them to pee it off through these diuretics. If our patient's admitted and we're giving them IV diuretics, they might benefit from an external catheter, so like one of those externally placed urinary catheters. We don't want an internal catheter because that's going to increase our risk of UTI, but they might be peeing so much and they're so tired and they can't get out of bed very much that external catheter that sucks away the pee can be very beneficial to help not tire them out with the frequent toileting. We use vasodilators as well, but that as long as they're not hypotensive. This helps reduce the preload and the afterload. And so does morphine, actually. So morphine, it's not for the pain, it's actually to help reduce preload and afterload. But we do need to watch our patients very closely if we are giving them morphine, because, again, we get that respiratory depression, and these patients are already having issues with their respiratory system. Our inotropes help with cardiac output. It increases the contractility of the heart. So this is where, like, if they're having an acute exacerbation, this is what we're going to be going for when they're hospitalized. Versus chronically at home, these are some of the medications that they're going to be on. So ACE inhibitors, ARBs, aldosterone antagonists, beta blockers to help reduce the cardiac output, digoxin, diuretics as well. And these medications are associated with a reduced morbidity and mortality, as well as on a reduction in the hospitalizations and symptoms. The other thing is we do want to be educating our patients on some of the things that we're teaching them. So remember, we talked about how patients, if they have that paroxysmal nocturnal dyspnea, they can sit up and dangle their feet. We need to teach them that it's okay to dangle their feet to help get some of the fluids there. They can also sleep with extra pillows to help keep them a little bit supported, keep them a little bit up so that the fluid's draining down. Low sodium diet to help with that water retention. And then those daily weights that we talked about, we definitely want to call. We want the patients to call their clinic, call their doctor if they have a weight gain of 3 pounds in 2 days or 3 to 5 pounds in a week. So that's another thing we want to educate them on. As well as, so this poor adherence to diet and medication regimen is the most common reason for these acute decompensations. Patients don't like being hospitalized. So if we can provide them with as much education as we can to help them reduce their chance of these acute decompensation, let them know, like, hey, if you're not adhering to these medications very well, if you're eating a high salt diet, like, this can definitely impede things and bring about these acute decompensations, these acute exacerbations. So just stressing the importance of these things to our patients, as well as helping them find the tools to keep on that regimen. So if they're on a delivery process for their medications, making sure that they're ordering ahead of time so that they get their medications on time and they're not having a gap between their medications and that sort of thing. Okay, that's all that I have for heart failure. In our last video, we're going to go into some of the vascular disorders, and that'll be it for cardiac.